Welcome back to the deep dive. Today, well, we're tackling something really ambitious. We had a specific request, actually, to go really deep, not just familiar, but aiming for true mastery of the surgical anatomy of the neck.
It's a crucial area. This compressed corridor, as you put it, it's packed with vital structures. Precision isn't just ideal, it's absolutely necessary.
Exactly. So our mission today is to unpack that complex framework. We're talking triangles, lymph node levels, those tricky fascial layers, and of course the neurovascular bundles that represent, well, constant hazards.
Understanding that organization, the potential dangers, the key landmarks, that's foundational. It underpins everything we do in head and neck surgery. It's not just about knowing what's there, but how it all relates spatially.
Right. So this knowledge directly supports a whole range of procedures. The big ones, obvious.
Wow, yeah, the major neck dissections, radical, modified radical, selective, we'll definitely get into those.
But also things like submandibular gland excisions.
Absolutely. And managing things like branchial cleft cysts, doing lymph node biopsies safely, and even setting up for microvascular anastomosis in reconstructive cases. It all comes back to this core anatomy.
Okay, let's define our territory. We're talking the surgical neck from the skull base, the clivus specifically, right down to the root of the neck.
That cervicothoracic junction, yes. Bounded by the first ribs, the sternal notch, and about the T3 vertebral body posteriorly.
And primarily we're focused on the anterior neck, the area in front of the trapezius muscle.
Precisely. The posterior neck, behind the traps, that's usually spinal surgery territory. Our field is divided by the SEM, the sternocleidomastoid, into those classic anterior and posterior triangles.
Got it. That sets the stage. Okay, mastery starts with organization. Surgeons need a common language, especially for cancer staging and treatment planning. Which brings us straight to the 6 surgical levels I-through system. Why this system? Why is it so critical?
It's about standardization, consistency. If pathology comes back saying levels IA and nodes are involved, every surgeon knows exactly what that means anatomically, which nodes, near which nerve in this case, the accessory nerve.
It dictates the scope of surgery then.
Exactly. It allows for targeted, selective neck dissections. You remove what's at risk, you spare what isn't.
That's the goal.
All right, let's break down these levels. Starting at the top, level 1, supraoid. It's split into IA and IB.
Correct. Level I is all above the hyoid bone. Level IA is the submental triangle. Think right under the chin, midline.
Boundaries.
The anterior bellies of the digastric muscles laterally, and the mylohyoid muscle forming the floor. Key drainage for, say, the floor of mouth, lower lip.
And just next door, level IB.
Level IB, the submandibular triangle. Bigger space, defined by the mandible superiorly and the anterior and posterior bellies of the digastric muscle below.
And this is where the submandibular gland lives.
The whole gland plus its lymph nodes, and as we'll see, some important nerves and vessels pass right through here too. Okay, moving down. Level 2, upper jugular nodes. And this is where a major nerve comes into play as a divider.
The spinal accessory nerve. Cranial nerve agafen. It's the key landmark here. Level diam is anterior to the accessory nerve. That's where most of the upper jugular nodes are.
Bounded superiorly by the digastric, or skull base sometimes, and inferiorly.
Inferiorly, the hyoid bone, or maybe more reliably for surgeons, the carotid bifurcation. Level II is the bit above and posterior to the accessory nerve, stretching up towards the skull base.
And knowing II versus II is critical for nerve-sparing surgery.
Absolutely. If the disease is confined to II, you know you have the nerve separating it from II, guiding your dissection plane.
Continuing down the carotid sheath, level 3.
Level 3 runs from that carotid bifurcation level down to, clinically, the cricothyroid notch. Surgically, the inferior border is often cited as the omohyoid muscle.
But you flagged a caution there in the sources.
Yes, you have to be careful with the omohyoid. It's a strap muscle. It moves. Flex the neck, extend the neck, and the omohyoid shifts. So, relying on it as a perfectly fixed landmark for the bottom of level 3, it can be a bit variable.
So better to use the cricothyroid notch or the bifurcation.
Those are more fixed references, yeah.
Right above the collarbone then, level 4.
Level 4, the lower jugular nodes, bounded above by that, well, variable omohyoid, and below by the clavicle. That's a solid boundary.
And access here is tricky.
It gets deep here. You're getting close to the major vessels at the root of the neck, the subclavian vessels. And on the left side, you have the thoracic duct lurking. Big hazard.
Okay, swinging laterally now to the posterior triangle. That whole space is level V.
That's level V, bounded by the trapezius behind, the SCM in front, and the clavicle below. And just like level 2, the accessory nerve is the key divider here.
Dividing it into VA and V.
Correct. V is superior above the nerve. V is inferior, below the nerve, closer to the clavicle. And the critical thing here, the nerve becomes really, really superficial in level V. Very easy to injure.
Even with just a superficial biopsy.
Definitely. High-risk area for the nerve.
And finally, the midline. Level 6.
Level 6, the anterior compartment. Hyoid bone down to the suprasternal notch. Laterally, it's bounded by the medial edge of the carotid sheath on each side.
What's in there?
This is the visceral compartment. Thyroid gland, parathyroid glands, trachea, esophagus, the recurrent laryngeal nerves, and the central compartment lymph nodes.
That framework is clear. Now let's connect this anatomy to a common clinical issue mentioned, brachial cleft cysts. Where did these come from embryologically?
It goes back to about the 5th week of development. You have these pharyngeal arches forming the neck, separated by clefts. Normally, the 2nd, 3rd, and 4th clefts kind of fold inwards and obliterate, forming a temporary thing called the cervical sinus.
And if that doesn't disappear completely,
Remnants get left behind. And those remnants can later swell up and form these cysts, brachial cleft cysts.
clinically, how do they usually show up?
Typically in younger adults, say 20s or 30s. Soft lump, usually right along the anterior border of the SCM muscle.
But the sources stress the importance of patient age. Why is a similar lump in someone over 40 such a red flag?
Because in that older age group, a cystic neck mass, especially in that location, has to be considered metastatic squamous cell carcinoma until proven otherwise. The differential diagnosis completely shifts.
So you're immediately thinking cancer first.
They have to. Distinguishing a benign developmental cyst from metastatic cancer becomes the absolute priority. And the type of cyst, where exactly it lies, tells you about its embryological track, which can run dangerously close to the carotid artery and cranial nerves. Knowing that path is vital for safe removal, if it is just a cyst.
Okay, let's move from the levels to mapping the surface. A surgeon needs reference points they can feel before they cut. We need to link surface landmarks to the deep cervical vertebrae, C1 through C6.
Yeah, this gives you a sort of vertical ruler for the neck, helps orient you, especially if you're dealing with something deep.
All right, starting high. The hard palate roughly corresponds to
C1, the anterior arch of the atlas.
the angle of the mandible. Easy to feel that.
That lines up with C2.
The hyoid bone, that floating bone above the voice box.
That's at the C3 level.
Then the thyroid notch, the Adam's apple prominence.
Usually the upper border of C4, maybe the C3, C4 disc space.
And just below that, the cricoid cartilage.
The anterior arch of the cricoid cartilage sits at C6. This is a really important one.
Why is C6 so key?
Well, several reasons. It's where the vertebral artery often enters the transverse foramen. It's the level of the middle cervical sympathetic ganglion. And crucially, it marks the location of the cricothyroid membrane, just below the thyroid cartilage.
The spot for an emergency airway.
Exactly. Cricothyrotomy. Knowing C6 means you know exactly where that life-saving membrane is. It's tough, fixed, reliable.
And a practical warning, C6 can feel lumpy.
Yes, the transverse processes of C6 are quite prominent laterally. They can easily be mistaken for a pathological neck lump on palpation. Worth keeping in mind.
Okay, lowest point, the sternal notch, the dip at the top of the breastbone.
That lines up approximately with the upper part of T3, so that gives us our full C1 to T3 map.
Now, nerves. Two superficial nerves are highlighted as being particularly vulnerable. Let's map the accessory nerve, XI, first. Where do we find it superficially?
The accessory nerve. Notoriously variable course. The classic description is that it exits the posterior border of the SCM around the junction of the upper and middle thirds.
So divide the SCM into thirds, find that point.
And then it runs obliquely down and back across the posterior triangle to dive under the anterior border of the trapezius, roughly 5 centimeters above the clavicle. But that's just a guide.
Is there a more reliable relationship? The source mentions the great auricular nerve.
Yes, that's often more helpful clinically. The accessory nerve usually emerges about 1 centimeter above the point where the great auricular nerve curls around the posterior border of the SCM. Find the great auricular, look slightly superiorly.
Okay, so where do we reliably find the great auricular nerve?
The great auricular nerve, that's sensory from C2 and C3, emerges right around the midpoint of the SCM's posterior border. You can measure it's roughly 6.5 centimeters below the external ear canal.
And preserving it matters for sensation.
Definitely. It supplies the skin over the angle of the jaw, the mastoid area, and crucially, the earlobe. Losing it leads to numbness there, which patients often find quite annoying.
Is there a vessel nearby to help locate it?
Yes, it's typically about 1 centimeter posterior to the external jugular vein, EJV, as the EJV crosses the SCM. So, Find the EJV, look just behind it at the SCM midpoint, and you should find the great auricular nerve.
We've got the framework, the landmarks. Now let's peel back the layers. Muscles first. We know the suprahyoids define level I. What about the infrahyoids, the strap muscles below the hyoid?
Right, the strap muscles. They control the larynx and hyoid position. They lie in two planes. Superficial plane have the sternohyoid and the omohyoid.
And the deep plane?
Sternothyroid and thyrohyoid.
Of these, the omohyoid keeps coming up as a key surgical landmark. Why?
Because, despite its variability moving up and down, its relationship to the major vein is consistent. The omohyoid muscle is always superficial to the internal jugular vein, IJV.
Ah, so it acts like a protective layer or a guide.
Exactly. If you're dissecting and you stay superficial to the omohyoid, you know you haven't gone deep enough to inadvertently injure the IJV. It's a very useful plane.
Okay, deeper still, near the vertebrae, we have muscles like the scalenes, longus capitis, longus colli.
Those are the deep prevertebral muscles. They form the floor of the posterior triangle, essentially. They lie deep to the prevertebral fascia, which is our next critical layer.
Right, the fascial layers. Described in the source as a terminological pain in the neck because the naming can be confusing in different texts. But functionally, we need to understand the key ones. Starting superficially.
Immediately under the skin, you've got the platysma. It's technically a muscle, but it's embedded within the superficial fascia.
Thin, broad sheet, mostly anterior and lateral neck. Innervated by the facial nerve's cervical branch.
Correct, CN0. It blends down with the fascia over the pecs.
And it has cosmetic relevance.
Very much so. If the medial borders of the platysma separate or weaken with age, you get those vertical bands in the neck, sometimes called turkey neck. Tightening that up, platysmoplication, is a standard part of a neck lift.
Okay, deep to the platysma and its superficial fascia, we hit the first layer of deep cervical fascia, the investing layer.
This is the one that acts like a collar. It completely encircles the neck. And importantly, it splits to enclose the two big superficial muscles, the SCM and the trapezius.
And it also encloses structures higher up, like the parotid gland.
Yes, superiorly, it splits to form the capsule around the parotid gland, the parotid fascia.
Yeah.
And because that capsule is tough and unyielding.
That's why parotid swelling, like in mumps, is so painful.
Yeah.
Got it.
Right. The gland swells. Pressure builds up inside that tight fascial envelope.
Crucially, what nerves run within this investing layer?
This is vital. The marginal mandibular branch and the cervical branch of the facial nerve lie within this layer, just deep to the platysma, but superficial to the deeper structures.
So when dissecting superficial flaps, you need to be mindful you're in the right plane relative to this investing fascia to protect those facial nerve branches.
Absolutely. Especially the marginal mandibular, damaging that causes the dreaded lower lip droop.
Okay, now the deepest layer, that's our main surgical barrier, the prevertebral fascia.
This is the final frontier, the safety barrier. It's a dense, strong layer covering the prevertebral muscles, the longus collis, longus capitis, scalens, and the vertebral bodies themselves.
And the surgical rule is?
Go through the prevertebral fascia at your peril. Simple as that. You dissect down to it, you clean the fat off it, but you do not intentionally breach it in a standard neck dissection.
Why such a stark warning? What's immediately behind it?
Two absolutely critical sets of nerves. The entire brachial plexus, supplying the arm, emerges between the anterior and middle scalene muscles, right under this fascia.
And the other one?
The phrenic nerve, C345, the sole motor supply to the diaphragm. It runs vertically down on the anterior surface of the anterior scalene muscle, again, just deep to this fascia.
So breaching the fascia risks paralysis of the arm or the diaphragm.
Precisely. Catastrophic complications. That's why surgeons often use a blunt technique, like gently wiping with a damp swab, to separate the overlying fatty tissue from the fascia without tearing through it.
But some nerves do have to pass through this fascia to get to the surface, right? The sensory nerves we talked about earlier.
Yes, the sensory branches of the cervical plexus have to pierce it. The lesser occipital, C2, great auricular, C2-3, transverse cervical, C2-3, and the supraclavicular nerves, C3-4. They emerge from deep to the fascia near the posterior border of the SCM.
And preserving those maintains sensation in the neck and shoulder region.
Yes, important for patient comfort post-operatively. The main motor nerve emerging is actually part of the ansus cervicalis, specifically the C2-C3 contribution, which loops around to supply the strap muscles.
Let's zoom back in on level I, the suprahyoid region. The floor is the mylohyoid muscle. It separates the neck from the oral cavity.
Correct. And it gets its nerve supply from the nerve to mylohyoid, which is a branch of the mandibular nerve, V3.
And there's a specific warning about this nerve in bilateral procedures.
Yes, this is a subtle but important point. If you're doing a neck dissection on both sides, levels IA and IB bilaterally, and you inadvertently cut the nerve to mylohyoid on both sides.
The patient can't swallow properly.
Exactly. Paralysis of the mylohyoid, the floor of the mouth, severely impacts the initiation of swallowing. Can lead to significant dysphagia.
Okay. Level IB also contains the submandibular gland. How is that gland situated?
It's kind of J-shaped. It has a larger superficial part below the mylohyoid and a smaller deep part that hooks around the posterior free edge of the mylohyoid muscle to lie on its upper surface within the floor of the mouth.
And the duct comes from the deep part.
Yes, the submandibular duct, Wharton's duct, arises from the deep part and runs forward in the floor of the mouth to open near the frenulum of the tongue. That hook around the muscle makes excision a bit tricky.
Now, the classic relationship in this area. Facial artery and marginal mandibular nerve. What's the key spatial arrangement?
The facial artery usually loops up from the carotid, often passes through or is closely related to the submandibular gland, and then crosses the inferior border of the mandible to supply the face.
And the nerve, the marginal mandibular branch of the seven.
The crucial point is that the nerve crosses superficial to the facial artery and vein as they cross the mandible. It's running within that investing fascial layer we talked about.
So the protective maneuver is?
Identify the facial vessels low down, near the gland, or as they cross the mandible. Carefully ligate them, and then retract the cut ends upwards towards the mandible.
And that pulls the nerve up with the vessels out of harm's way.
That's the idea. Retracting the vessels superiorly lifts the nerve, which runs superficial to them, hopefully keeping it safe during the rest of the dissection in level IB.
The digastric muscle, outlining level 1, is mentioned as a safe guide. Why?
Because generally, no vital structures cross superficially over the digastric muscle bellies. You can follow the muscle planes relatively safely.
But the danger lies deep to it.
Exactly.
Yeah.
Deep and superior to the posterior belly, you risk hitting the lingual nerve. Deep and inferior, you find the hypoglossal nerve. And deeper still, medial to the angle of the jaw, lie the major carotid artery branches. So, safe guide, but be very aware of what's underneath.
The sources mention a specific plan B for vascular access if the facial artery isn't usable for, say, microvascular reconstruction. Pirogoff's triangle.
Yes, this is a neat surgical anatomy point for accessing the lingual artery directly. It's a small triangle deep in the submandibular region.
What are its borders?
Inferiorly, it's the intermediate tendon of the digastric muscle. Anteriorly, it's the posterior border of the mylohyoid muscle. And superiorly, it's the hypoglossal nerve itself.
And the floor of that triangle
Is the hyoglossus muscle. You dissect through the hyoglossus within those boundaries, and you'll find the lingual artery. It's a specific, targeted approach for when you need that vessel, and the facial artery isn't an option.
Okay, let's pull back the SCM muscle now and look deep into levels 2, 3, and 4. This is the realm of the carotid sheath. First, let's revisit the accessory nerve, FS here. Where is it found deep to the SCM?
After exiting the SCM, it typically runs across the floor of the posterior triangle. But before that, deep to the SCM, it's usually found emerging between the SCM and the posterior belly of the digastric.
And its relationship to the internal jugular vein, IJV here.
Most commonly, it passes superficial to the IJV. That's the textbook position.
But variants exist.
Oh, yes. It can pass deep to the IJV. And rarely, but importantly, it's been documented to actually penetrate the wall of the IJV and run through it for a short distance.
Wow. That would be challenging during surgery.
Extremely. Imagine trying to dissect the vein clear and finding the nerve literally inside it. Requires very careful handling.
Are there other variants, like how it supplies muscles?
Yes, sometimes the nerve splits early. One branch might supply the SCM, while another branch passes deep to the SCM to get to the trapezius. And there's even a variant where the SCM gets some supply from a branch that seems to come off the ansa cervicalis loop, specifically the C1 component via hypoglossal, up to 4% apparently.
Reinforces the need for meticulous identification, not just assuming the textbook path.
Always. Treat every nerve as potentially variable.
Okay, the main event deep to SCM, the carotid sheath. What exactly is it and what's inside?
It's a condensation of the deep cervical fascia that bundles together the main neurovascular structures.
Yeah.
Inside, you have three key things. The internal jugular vein, IJV, always the most lateral structure.
Okay.
Then the common carotid artery, which bifurcates into the internal and external carotid arteries within the upper part of the sheath territory. These are medial to the vein.
And the third component?
The vagus nerve, cranial nerve X. Its position is critical. It lies between the IJV and the carotid artery. Often slightly posterior, sometimes described as being in the groove on the a lateral aspect of the artery.
So protected somewhat if you're working anteriorly, but vulnerable if dissecting posteriorly.
That's a fair way to think about it.
Now, what important structure runs near the sheath but is definitely outside it?
The sympathetic chain. This runs vertically, parallel to the sheath, but it's located posteromedial to the sheath, lying directly on the prevertebral fascia. It's outside the sheath proper.
And if that gets damaged during dissection?
That leads to unilateral Horner syndrome. You get that classic triad, ptosis, droopy eyelid, meiosis, constricted pupil, and anhydrasis, lack of sweating, on that side of the face. It's a clear sign that dissection went too far posteromedially.
Let's talk about the hypoglossal nerve again as it crosses this area. Where does it run relative to the big vessels?
The hypoglossal nerve loops forward, crossing both the internal and external carotid arteries, usually deep and just below the posterior belly of the digastric muscle.
And the source mentions specific hazards around it.
Yes, two things.
Mm-hmm.
First, it's often surrounded by a very delicate plexus of small veins. Trying to dissect the nerve cleanly often causes annoying, persistent bleeding from this plexus, which can obscure your view.
And the second hazard?
It's quite sensitive to heat damage from diathermy or electrocautery. Careless use of cautery near the hypoglossal can easily lead to nerve injury and tongue paralysis.
Resulting in the tongue deviating towards the injured side when stuck out.
Correct, along with potential issues with speech and swallowing.
We also mentioned the ansa cervicalis, formed by contributions from C1 via hypoglossal and C2, C3. Where does this loop run relative to the IJV?
The ansa cervicalis loop itself runs anteriorly, crossing superficial to the internal jugular vein. Remember, its job is to supply the infraoid strap muscles, which are anterior.
So it's distinct from the vagus, which is deep and posterior within the sheath.
Yes, important distinction. The ansa is superficial to the vein. The vagus is deep between the vein and artery. And remember that C1 variant where it might give a branch to the SCM adds complexity.
Dropping down into level 4, near the clavicle, access gets tough here.
Yes, level 4 is separated from the third by the omohyoid superiorly, but inferiorly it runs down to the clavicle. Space is tight, and you're right on top of the subclavian artery and vein as they head towards the arm.
And there's a warning about the subclavian vessels themselves.
Yeah, occasionally, instead of passing under the clavicle, the subclavian vein or even artery can loop above the clavicle. Extremely rare. But imagine encountering that unexpectedly during a level 4 dissection. Major hemorrhage risk.
Level 4 is also home to the biggest fluid hazard, the thoracic duct, but only on the left side.
Primarily on the left, yes. It's the main lymphatic channel draining most of the body. Its anatomy near its termination is highly variable.
Where does it usually run?
Often along the medial border of the anterior scalene muscle, deep in level 4. It then arches forward to drain into the venous system, typically near the junction of the left internal jugular vein and the left subclavian vein.
Usually above the clavicle.
Yes, somewhere between maybe 0.5 centimeter and 4 centimeters above the clavicle. But its exact entry point, and whether it's a single duct or multiple branches, is very unpredictable.
Making it easy to injure.
Very easy, especially during dissection low in level 4 on the left.
If it is injured, how does the leak present? The source mentions the fluid looks different depending on diet.
Right. If the patient is fasting before surgery, the lymph fluid, chyle, will be clear, maybe slightly straw-colored. Easy to miss intraoperatively, but postoperatively. Once the patient eats fatty foods, the chyle turns milky white because of the absorbed fats.
And a chyle leak is serious.
Yes, it needs prompt management, often surgical ligation of the duct. Losing large volumes of chyle leads to significant fluid, protein, and electrolyte depletion.
Finally, related to the IJV in this deep dissection, the absolute warning against taking both IJVs at the same time.
That's a fundamental rule. Bilateral synchronous IJV ligation is contraindicated. The venous drainage from the head relies heavily on the IJVs. Taking both out at once causes massive venous congestion, increased intracranial pressure, severe facial and neck swelling, potentially life-threatening. It's avoided at almost all costs.
Okay, let's move to the last major region, the posterior triangle, level V. We've established the key structure here is the accessory nerve. It's the most important and the most vulnerable.
Absolutely. Most important because of the function of the trapezius muscle it supplies. Most vulnerable because after it exits the SCM, it runs very superficially across the fatty tissue of the posterior triangle.
And it divides the triangle into V above, VB below.
Correct. It's the defining landmark within level V.
What else runs with the nerve here?
A chain of lymph nodes runs along the course of the accessory nerve. This is important if you're doing a node biopsy in level V. The nerve is right there with the nodes.
What about blood vessels in level V?
The main ones are the transverse cervical artery and vein. They run across the triangle, usually superficial to the prevertebral fascia. And again, that rare possibility of the subclavian vessels looping high.
Let's really emphasize the consequences of damaging that accessory nerve. What happens functionally?
It's devastating for shoulder function. The primary issue is paralysis of the trapezius muscle. This leads to significant limitation of shoulder abduction. The patient can't lift their arm out to the side, usually struggling beyond 90 degrees.
And the appearance.
You get characteristic winging of the scapula. The shoulder blade sticks out from the back because the trapezius isn't holding it in place. The whole shoulder girdle destabilizes.
And the source mentions chronic pain.
Yes, often a troublesome aching pain around the sternoclavicular joint. It's thought to be due to the biomechanical changes. The shoulder dropping, the clavicle rotating abnormally because of the muscle imbalance.
Yeah.
It puts strain on that joint.
Which makes preserving the nerve, whenever oncologically safe, the absolute priority.
It's the gold standard. Even if it requires meticulous, time-consuming dissection around involved nodes, the functional benefit of saving that nerve is immense. Relying on possible alternative innervation from the cervical plexus isn't a reliable strategy.
Okay, to wrap up the anatomy, let's clarify the terminology for the standard neck dissections themselves based on the sources. Radical, modified radical, and selective.
This is the language surgeons use to communicate exactly what was done.
Start with the oldest, most expensive. Radical neck dissection, RND.
RND means removing everything. All lymph node levels, I through V, are removed en bloc. Plus, you sacrifice the three major non-lymphatic structures, the sternocleidomastoid muscle, SCM, the internal jugular vein, IJV, and the spinal accessory nerve.
Reserved for very advanced disease.
Typically, yes, where maximum clearance is deemed necessary, despite the functional cost.
Then, the modified radical neck dissection, MRND. This aims to preserve function.
Correct. MRND also removes levels I through V, but it specifically preserves one or more of those three key structures, SCM, IJV, accessory nerve.
And it's typed based on what saves.
Exactly. MRND type 1 saves one structure, usually the nerve. MRND type 2 saves two structures, Fuji nerve and SCM. MRND type 3 saves all three structures, nerve, SCM, and IJV. This obviously gives the best functional outcome, but requires the disease to be clear of those
For
structures.
the most tailored approach, selective neck dissection, SND.
S&D is where anatomical knowledge really shines. You only remove the specific lymph node levels thought to be at highest risk based on the primary tumor site and pathology.
And documentation is key here.
Absolutely critical.
Yeah.
You must specify which levels were dissected. For example, S&D levels 2 to V, left side. This tells everyone that levels I and V were preserved. It's precise, aiming to minimize surgical morbidity while achieving oncological control.
That clear terminology is essential for communication and comparing outcomes. It really ties the anatomy to the surgical practice. Hashtag had outro.
So pulling all this together, what we've really done is build a multi-layered map. Mastery comes from seeing the planes, knowing the reliable guides like the digastric or the omohyoid seeing superficial to the IGV. It's about having instant recall of those three highly vulnerable superficial nerves: marginal mandibular, great auricular, accessory.
And knowing the deep hazards.
And knowing the deep hazards you absolutely must avoid by respecting the prevertebral fascia, the grenic nerve, the brachial plexus, and on the left, that unpredictable thoracic duct.
And we highlighted two absolute do-nots: sacrificing the accessory nerve and what's truly unavoidable for cancer clearance.
Because the disability is so significant.
And never ever ligating both internal jugular veins in the same operation.
Non-negotiable.
Yeah.
Those are fundamental safety principles grounded directly in this anatomy.
Okay, this brings us to our final provocative thought for you today. We spent a lot of time on the standard anatomy, but we also repeatedly highlighted documented anatomical variants, the accessory nerve piercing the IJV, nerve supply anomalies like C1 to the SCM, the subclavian vessels riding high. These aren't just theoretical, they happen.
They do. Every experienced surgeon has encountered surprises.
So the question is, in a complex cancer surgery, maybe a salvage case where time is critical, how does the surgeon reconcile the need for meticulous, slow dissection, the kind needed to identify and manage these unexpected variants safely, with the pressure to proceed efficiently, perhaps even quickly? What does the reality of anatomical variation tell us about the limits of textbook knowledge? And how much does surgical mastery ultimately depend not just on knowing the map, but on skilled judgment and adaptation in real time?
That's the art meeting the science, isn't it? Something to definitely ponder after this deep dive.